All right, well, it's very difficult to show you better examples of HCCs and talk about HCC after Stephanie's talk, but most of the cases that she showed you and most of the patients that you will see in your practice will be patients with relatively normal liver. But there is a large and growing population of patients with cirrhosis or other risk factors for HCC that will have pretty high pretest probability of HCC, and they also will develop innumerable benign, regenerative, and dysplastic nodules. They will develop early HCCs that are not as bad as poorly differentiated HCCs. They will have slightly less chance of developing cholangiohepatomas. So we're going to talk about this specific patient population with high pretest probability of HCC and extremely high risk of relatively benign hepatic nodules, and see how contrast-enhanced ultrasound can help you make a diagnosis of HCC in those patients and also stratify them and provide appropriate management recommendations. HCC is extremely common cancer worldwide. It's the second leading case of cancer death in the world. It's a 6th or 7th leading case of death in the United States, and incidence is growing significantly. If you look at the changes in the incidence of cancers, all of the cancers that we've been aggressively treating in the last several decades are actually decreasing. We are doing pretty good job decreasing lung and colon cancer thanks to screening. Breast cancer incidence is decreasing. Prostate, we pretty much get under relative control, but liver cancer is the only one that is growing extremely fast. It's adding 2.7 to 3% annually, and it's mainly due to cirrhotic patients, patients with chronic hepatitis that develop cirrhosis, and also NASH and fatty liver patients that go into cirrhotic disease as well. AASLD, which American Association for Study of Liver Disease, used to have this nice and easy table that can tell you what to do with those patients based on the 2010 liver guidelines. If liver lesion is less than 1 centimeter, they would go into repeat ultrasound programs to try to understand what's going on with this lesion. If it grows or becomes greater than centimeter, we're going to start doing dynamic contrast-enhanced CT or MRI or contrast-enhanced ultrasound trying to characterize this lesion. Thanks to efforts of ACR, AASLD in their most recent guidelines in 2018 accepted LI-RADS as one of the ways to stratify lesions, and they base all their recommendations based on LI-RADS. LI-RADS was developed initially for CT and MRI, but we added contrast-enhanced ultrasound to it, and hopefully in the next versions, not only CT and MR, but also contrast-enhanced ultrasound will be included in AASLD guidelines. But I personally use contrast-enhanced ultrasound in my practice for patients at risk for HCC, and we grade our findings according to LI-RADS templates. Again and again and again, it's extremely important to follow protocol. And one of the most important achievements that I think we got with this LI-RADS contrast-enhanced ultrasound working group efforts, we designed this very strict protocol that we follow in every liver case that we scan. You can grab some papers with this protocol at the back, but basically Stephanie and Richard and I all talk about the same thing. You inject microbubbles first, you image from the injection until you see peak arterial phase enhancement. You save images from the first arrival of the microbubbles until peak enhancement, or in some patients you might want to extend it until 1 minute and you stop. And then you go back, acquire small tiny screenshots of the late washout for 5, 6, 7, 8 minutes. Classic HCC, and based on all the recommendations before LI-RADS, malignant tumors are characterized by arterial phase hyperenhancement and washout. But if you just look at those two parameters, you will not be able to tell HCC from METS or cholangiocarcinoma, and LI-RADS addresses all of this. It's available on ACR's website. There is a folder for LI-RADS, for CT, MR, screening ultrasound, and contrast-enhanced ultrasound. If you need a reference, you can go to ACR website and get that classification system for your use. It's very important to understand that we only apply LI-RADS characterization scheme to patients who are at risk for HCC. We do not apply LI-RADS to patients with normal livers. We do not apply it to patients who are young, with cirrhosis due to congenital hepatic fibrosis and other congenital causes. We only, at this point, recommend for beginners, so people who in the early stages of contrast-enhanced ultrasound practice development, to only apply this to lesions visible on pre-contrast ultrasound. Later, when you become more comfortable and confident with this technique, it is totally fine to apply contrast-enhanced ultrasound to lesions that you do not see on pre-contrast ultrasound using anatomical landmarks, image fusion, and whatnot. But to begin, honestly, I would strongly recommend that you only do it if you see a lesion well on B-mode ultrasound. We do not assign categories of LI-RADS that are pathologically proven malignancies or that are path-proven benign lesions of non-hepatocellular origin like hemangiomas. If you have pathology, you don't need LI-RADS. You only apply it to lesions that are not biopsied, or we don't know what we are looking at. At this point, out of 3 contrast agents, we have more experience with Definity and Lumason, or some of you in Europe. Optison is a great agent for other applications, but for liver, it just doesn't last as long. So we try to concentrate on Lumason and Definity. However, if Optison is the only thing you have in your hospital, you might try, but you might not see late washout of your lesions. There are several major criteria that we use for LI-RADS characterization. Stephanie went over all of them, but hyperenhancement, when you have increased enhancement in the lesion compared to the surrounding parenchyma in the arterial phase, when the normal liver and portal veins remain relatively unenhanced. Nodal and nodal architecture happens in HCCs, and we use it as one of the ancillary features. When you have relatively hyper-enhancing nodal with a dot of the very bright arterial phase hyperenhancement. This favors HCC, although it's not diagnostic of HCC. Arterial phase rim enhancement implies malignancy, but it's not specific for HCC. Lots of metastatic lesions or cholangiocarcinoma will have this rim of enhancement, which immediately 15 seconds after contrast injection start washing out. If you see this, it goes to LI-RADS M or malignancy not specific for HCC category. Some of those lesions will be iso-enhancing. There is no difference in arterial phase between enhancement of this lesion and normal parenchyma, but please try to compare nodal enhancement to the liver at the same depth, because superficial areas of the liver might enhance a little bit more than deep. So if you have lesion in the deep portions of the liver, look at the liver enhancement along the same depth to judge echogenicity of those lesions. Hypoenhancement, it happens in necrotic lesions. Lots of metastases can get necrotic, but some degenerative nodules can have hypoenhancement in the arterial phase as well. Washout, washout, washout. This is one of the most important things to tell HCC from other lesions, and we need to observe 2 things when it comes to washout: timing, when it happens, and degree. Mild washout, as Stephanie said, is when lesion washes out. It is obviously darker than surrounding liver, but you still have substantial amount of ultrasound contrast floating through the lesion. And then marked washout when you have pretty much black hole. One of the important things to mention that we want to assess marked washout at 2 minutes after contrast injection. The reason for that, if you have mild washout, if you have this lesion and you watch it for 5, 7, 8 minutes, at some point, very, very late, will almost all contrast wash out, it will turn into black hole, but it doesn't mean there is a marked washout. It is still mild, and I would judge washout degree at the first occurrence. I wouldn't wait for 5-7 minutes for almost all bubbles to go away to judge it. So mild washout should have some contrast. Marked washout within first 2 minutes after contrast injection should turn into a black hole. Tumor in vein is another category that we use in LI-RADS when we're absolutely sure that echogenic material within the lumen of the portal vein is tumor. It will have arterial phase hyperenhancement. It will enhance in the arterial phase before portal veins fill with contrast, and then later on, will portal veins still enhanced with contrast, it will wash out, confirming malignancy in a portal vein, which unfortunately upstages HCC quite significantly. One of the problems that we all have with contrast-enhanced ultrasound, we really don't understand why all of this is happening. There is no perfect theory to explain why arterial phase hyperenhancement and washout happens. The most simplistic theory that kind of suits me at the current stage until we find perfect explanation for this is these changes in vascular networks in the liver that happens with cancerogenesis in patients at risk for HCC. So normal liver gets dual blood supply. 75% of the blood comes from portal vein, about 25% of the blood comes from the hepatic artery. And when you start developing low-grade degenerative nodules going into high-grade degenerative nodules, you will have drop in your arterial supply and some drop in the portal vein supply. So degenerative nodules will show up as hypo-enhancing lesions. We see those small tiny dots of decreased enhancement in the arterial phase quite often. If they're less than 1 centimeter, they have hypo-enhancement, and then later they fill with contrast. We call them degenerative nodules, and we move on. When you get early HCCs, you're going to start developing neoangiogenesis. Those tumors will grow their abnormal tumor vessels, and they also destroy a significant amount of portal vein branches in them, so they kind of blend into the liver. And to me, this is one of the most difficult things to deal with when I see lesions that are definitely abnormal, round tumors on B-mode ultrasound. They tend to be small, maybe 1.5 centimeter in size. They quite often demonstrate no arterial phase hyperenhancement. Later, when you have well-established HCC, they will develop a ton of neoangiogenesis and loss of vessels, and they will be brighter in the arterial phase compared to the surrounding liver, and then full-blown HCCs will have nothing but arterial supply. Washout, again, lots of people disagree with this, but may be related to amount of portal vein flow. When you have enough portal vein flow to your tumors, they will not wash out, and then when they start tumors eating up those portal veins, they might start washing out. And we know for sure that early HCCs wash out less and to a lesser degree. Well-differentiated HCCs demonstrate this mild washout, and poorly differentiated HCCs quite often end up with marked washout that happens early, almost looking like metastatic lesions or other hepatic malignancy. And we tend to biopsy those lesions. Lesions with very, very early and marked washout will be labeled at LI-RADS M. We do biopsy them, and we don't act surprised when we get HCC back, because large proportion of those lesions are poorly differentiated HCCs, and oncologists will need to know the genetic profile of those tumors because they need to know markers, they need to know profile to treat those lesions appropriately. So for all practical purposes, again and again, it's arterial phase hyperenhancement and washout that signifies malignancy. But unfortunately, just these two, not enough to be specific. So we design this nice, beautiful algorithm, and I go over all the parts of it in LI-RADS, so you can characterize your lesions in 5 different categories, providing with your clinicians a relatively robust way to judge the risk of the HCC in each category. So arterial phase hyperenhancement is absolutely a requirement for LI-RADS 5 characterization. And again, LI-RADS 5 is definitely HCC. Once you make a diagnosis of LI-RADS 5 lesion, similar to CT and MRI, we will proceed with treatment without getting pathological diagnosis. All other lesions will go either into biopsy or follow-up, but LI-RADS 5 is pretty much diagnostic of HCC. Not all HCCs will get LI-RADS 5 category. Probably half or 60% of HCCs will, but close to 40 to 50% of HCCs will end up in other categories similar to CT and MR. And this is okay because we know what to do with LI-RADS 4 or LI-RADS M lesions. Once you give them LI-RADS 5, it's a definite HCC. It will go to treatment without biopsy. Without arterial phase hyperenhancement, you cannot have LI-RADS 5 lesion. So if you don't see it, you cannot diagnose it as definite HCC. Arterial phase hyperenhancement, when present, can take lesions into different categories, and then we add a washout, and size of the lesion, we can characterize them appropriately. Arterial phase hyperenhancement alone is not HCC, not LI-RADS 5. It can be LI-RADS 1 or 2, 3, 4, 5, or LI-RADS M. Second most important category is a washout. Typical washout of HCC is late in onset, happening 60 or greater seconds after injection. And because this is so important, I want to emphasize the importance of starting your contrast timer appropriately. We start our contrast timer at the end of the contrast injection, at the beginning of the flush. If you start it at the end of your flush, you already wasted 5-7 seconds for your injections. You're not going to make accurate diagnosis. So please be careful with timer because it's extremely important to get accurate diagnosis. Marked washout or early washout is LI-RADS M lesions, malignant but not necessarily HCC. Even though lots of HCC will fall into that category, we want to be very careful with them and potentially send them to biopsy. So two things: only late washout happening greater than 60 seconds after contrast injection, and mild contrast degree implies HCC. Rest of the washout, you need to look at other things, look at timing, look at degree, look at the presence of arterial phase hyperenhancement, and classify those lesions accordingly. Let's go over different LI-RADS categories. LI-RADS 1, definitely benign. Simple cyst, classic hemangioma, definite focal fat deposition or focal fat sparing, get those classifications. Lesion on MRI with arterial phase hyperenhancement and persistent enhancement, very difficult to make this diagnosis, could be anything. Some of the cholangiocarcinomas will look like this. On ultrasound, looks completely horrible. Targetoid lesion with dark center, very echogenic periphery. I would definitely worry about this lesion. I would send it for biopsy for sure, especially if patient has any history of malignancy or he is high risk for HCC. On contrast-enhanced ultrasound, beautiful peripheral interrupted enhancement, progressive filling, lesion remains hyper-enhanced on delayed images. This is hemangioma. Honestly, being an interventional radiologist part-time, I can tell you that this lesion is a complete disaster to biopsy if this comes to me because there are lots of vessels. There's portal vein confluence sitting right next to it. It's pretty deep. If you see big portal veins, meaning there are big bile ducts next to it, so biopsying this highly vascular tumor in the porta hepatis surrounding by all those structures is a disaster. So thanks God we figured it out and not biopsy this lesion. Focal fat, hyperechoic lesion, kind of poorly defined, but with some hypoechoic contour, kind of sketchy. Can be anything with contrast-enhanced ultrasound, no arterial phase hyperenhancement, no washout, focal fat can go back to normal surveillance. LI-RADS 2 lesions, probably benign. We're not 100% sure, but we have a feeling that probably okay. Solid nodules less than 1 centimeter in size, not distinct solid nodules of any dimensions where you cannot really put the calipers, or LI-RADS 3 indeterminate observation that's been stable for 2 or more years. Probably benign. They're not completely out of the our arms, but we'll just keep an eye on those lesions and they can go to routine surveillance. Everybody who does ultrasound of the liver in patients with cirrhosis, seen hundreds and thousands of them, they all drive us crazy, especially when we scan livers with high-resolution transducers looking for surface nodularity of the liver. No arterial phase hyperenhancement, no washout, LI-RADS 2 nodule, lightly regenerative nodule. You can leave those guys alone. Other lesions will require you consulting this table for further characterization. LI-RADS 3, 4, and 5 lesions will have to meet specific criteria, and we're going to be looking at size of the lesion, presence or absence of arterial phase hyperenhancement, and classic late and mild washout for LI-RADS 5 characterization, and then washout of any type for LI-RADS 3 and 4, or no washout of any time for LI-RADS 3 and 4 lesions. So LI-RADS 3 lesions, very suspicious mass in the liver, hypoechoic, solid lesion, well-defined, no arterial phase hyperenhancement, no washout early, no washout within 2 minutes, no washout at 4-minute LI-RADS 3. We don't know if this is HCC or not. The chances of this being HCC are actually probably 50 to 40%, so we would keep a very, very close eye on this lesion. I don't remember exactly, but I think this lesion turned out to be regenerative nodule. It had been stable for quite some time, or it was even taken out, and we have pathology on it. LI-RADS 4 is probably HCC. It smells like HCC. There is probably 90 to 85 to 90% chance of this being HCC, but we do not have all necessary criteria to call it definitely HCC. If you have arterial phase hyperenhancement but no washout whatsoever, or if you have no arterial phase hyperenhancement with classic washout, or if it's a lesion that is just too small for us to be confident in our diagnosis, we're going to give them LI-RADS 4 category and then closely observe it, maybe do something else, biopsy or CT-MR, trying to figure out what to do based on specific clinical situations. Two small nodules with arterial phase hyperenhancement, remain hyperenhanced, no washout. With arterial phase hyperenhancement, do you bump them up a little bit from LI-RADS 3 category, and we're going to assign them LI-RADS 4 in this case. LI-RADS 5, again, definitely HCC. We don't do anything with those lesions. They should go straight to treatment. Larger than 10 millimeter, arterial phase hyperenhancement with late or mild washout. In patients who are at risk for HCC, we can safely and confidently make a diagnosis of HCC. Indeterminate lesion, very similar to that hemangioma I showed you, with arterial phase hyperenhancement, washout that happens after 1 minute from contrast injection. And if you look here, this is the thing I was talking about. At 4 minutes, this lesion with mild washout will wash out to greater degree, and you might call this punched out lesion with marked washout. You might mistakenly call this LI-RADS M, but it's actually at the first occurrence within 2 minutes after injection, this washout was mild in degree, so call it LI-RADS 5. Tumor in vein is very unfortunate situation for our patients, like in this patient with large tumor and very heterogeneous hyperisoechoic material in the portal vein. We inject microbubbles. In a few seconds, you're going to see enhancement in the mass itself. And with the mass enhancement, you're going to see enhancement in the portal vein adjacent to the mass. So you have heterogeneous arterial phase hyperenhancement in the mass, and your portal vein tumor thrombus enhances with the mass in the arterial phase. Portal vein thrombus is tricky. It's tricky to differentiate tumor thrombus from recanalized blunt thrombus in a portal vein. It's extremely important to get very nice cine of the arterial phase and just go slide by slide. Tumor thrombus will enhance in the arterial phase when portal veins are not ossified. It will enhance with the tumor, and we quite often see tumor adjacent to it. Recanalized portal vein thrombus will enhance in a portal vein phase. It will enhance with main portal vein. And also, arterial portal vein tumor thrombus will demonstrate washout on late images like so, and then benign recanalized tumor thrombus will remain enhanced like surrounding portal veins. Cholangiocarcinoma, LI-RADS M lesion. Lesion very similar to that hemangioma I showed you as a LI-RADS 1 category lesion, arterial phase hyperenhancement with persistent enhancement, which is a hallmark of cholangiocarcinoma on MRI. Very early looking hypoechoic mass with hyperechoic border, arterial phase hyperenhancement almost immediately followed by washout that turns into a black hole a little bit later. LI-RADS M cholangiocarcinoma, you have to biopsy those lesions because just looking at contrast-enhanced ultrasound, you're not 100% sure what is going on. Other metastases will have very similar appearance, arterial phase hyperenhancement, washout that starts early, before 1 minute after injection, turning into black holes at 2 minutes. This is just to show you HCC and cholangiocarcinoma side by side. In the arterial phase, impossible to tell apart. They all demonstrate arterial phase hyperenhancement. Cholangiocarcinomas again start washing out early, turning into black holes, and then HCCs wash out late and demonstrate mild degree of washout. So after you come up with your category, anything other than LI-RADS 5, you can apply some ancillary features to move your characterization up or slightly down. Note that even if you have LI-RADS 4 lesion, you cannot use ancillary features to bump it to LI-RADS 5. LI-RADS 5, we decided to be very strict because those patients go to treatment without any confirmations. Ancillary features favoring malignancy in general, but not HCC in particular, is definite growth. And you can consult LI-RADS manual to see those growth numbers for CT and MRI. We didn't want to give you very strict guidelines for measurement on ultrasound because quite often those patients will be scanned on 2 different scanners. Ultrasound is, in some locations, might not give you exact definitions of the border wall. So if you, as your radiologist or sonographer, think that this is definitely growing, it's definitely increasing in size, you can use this ancillary feature to bump your characterization up a little bit. Ancillary features favoring HCC in particular is nodal in nodal architecture or mosaic architecture when you see in the large HCCs. And then if your lesion has been stable for greater than 2 years or it's shrinking in size, you can go from, let's say, LI-RADS 4 to downgrade this lesion to LI-RADS 3 so they can go back into routine follow-up. There is thing that is tie-breaking rules. The basic idea behind it, if you're not sure, go to category with less certainty. If you don't know if it's LI-RADS 5 or LI-RADS M, go to LI-RADS M, which is less certain, do something with this lesion. If you're not sure if it's LI-RADS 1 or LI-RADS 2, call it LI-RADS 2. You have to be absolutely, definitely, positively sure that this is benign lesion to call it LI-RADS 1, or definitely sure that this is HCC to call it LI-RADS 5. This is the probability of HCC in every different category. Not all HCCs will end up in LI-RADS 5 category. Probably half of them will end up somewhere else, and that's okay. We want to design this system so LI-RADS 5 implies 100% specificity for HCC. It's not going to be very sensitive, but you have to be absolutely sure that what you're seeing is definitely HCC so you can proceed with treatment. Management guidelines is actually kind of under development right now. We're still tweaking it. But if you have a patient who is at risk for HCC, if you give them LI-RADS 1 or 2 category definition, they should go to routine screening. LI-RADS 3 lesions usually go to multidisciplinary discussion, and you can discuss with your hepatologist and interventional radiologist what to do. Some of them will go into shorter screening intervals. Some might get CT or MR. In some cases, if you absolutely have to, you might biopsy them. LI-RADS 4 lesions are the same, but we're going to be a little bit more aggressive with them. Honestly, in some specific situations, since we know that those lesions have probably 80 to 90% chance of being HCCs, in our institution, when patients are on the border of getting kicked out of the transplant list, they go and treat those LI-RADS 4 lesions, or we biopsy them. So all of those discussions should happen at multidisciplinary conferences, so you know the background of this patient and know what to do with them. Because sometimes we have to be very aggressive. In some cases, we can wait and rescan this patient in 3 months or sometimes in 6 months to try to figure out what to do. LI-RADS 5 is diagnostic of HCC, don't need to do anything, goes to consensus on management. And LI-RADS M, usually biopsy, sometimes additional imaging, but honestly in our clinic, most LI-RADS M lesions end up with needles. And tumor in vein, very difficult situation to deal with. If you're not 100% sure it's a tumor, you might do something else. On occasion, we do biopsy those lesions, but again, that all should happen at multidisciplinary discussions, so you know your hepatologist and interventional radiologist input so you can make informed decisions about treatment. Okay, as a summary, HCC, very common cancer. It's growing rapidly. They will see more and more HCCs coming our way, so we need to be prepared to deal with them. And contrast-enhanced ultrasound on top of ultrasound screening is probably one of the best places to start, because if you have patients who come to your department for screening of HCC, if you find a lesion, in my mind, contrast-enhanced ultrasound should be next step. Because in most of the patients, if you definitely characterize those lesions in their livers as benign or give them LI-RADS 2 category, even sometimes LI-RADS 3, they can go back into routine screening. If you definitely know it's HCC, you can save them anxiety and expense of CTs and MRs, and they can go straight to treatment. Use LI-RADS for patients with risk factors for HCC. It will give you a nice characterization of the lesions. You can tell your referring clinicians what is the risk of HCC in each category, and they can manage those patients accordingly. Remember that LI-RADS 5 is definite HCC. They can go to treatment, so please be careful with that. Make absolutely sure that you have arterial phase hyperenhancement, size more than 1 centimeter, and late and mild washout for this category. LI-RADS M is malignancy. It's not specific to HCC. Biopsy them. Don't be surprised that half of the biopsies will come back as HCCs. Those are bad HCCs. They're poorly differentiated. They need pathology and molecular markers for appropriate treatments. Look at arterial phase hyperenhancement in the real time and washout during intermittent scanning. Do not burn all your bubbles in the first 2 minutes of constant scanning through the liver, because if you do, you will not see late washout. It is absolutely critical. And once you see washout, assess its timing and degree. ACR website have all those guidelines. Right now we have 2017 version, and hopefully we'll get 2019 version out soon. And if you have any questions, please feel free to call or email Yuko or any of the members of our fabulous contrast-enhanced ultrasound working group, and we'll be more than happy to work with you and answer any of your questions. And with that, if you have questions right now, I might start answering them immediately.
Yeah.
I have a question just for the three of you. We have a couple of gastroenterologists that send us patients every 6 months for C surveillance. Hi, we have a couple of gastroenterologists that send us patients every 6 months. They have hepatitis C, hepatitis B surveillance for HCC, and generally we just do non-contrast ultrasounds. And I was just wondering what your recommendations would be for surveillance in these patients that are at high risk. Should we do contrast ultrasound once a year, or what are your thoughts about that? Thanks.
I think there is a general consensus between working group members and people who use it that we would not routinely recommend contrast-enhanced ultrasound as a screening tool. Meaning if you have 20, 30 patients a day coming to your clinic for screening for HCC, I wouldn't do it on everybody routinely, right? You can help your referring physicians and patients by talking to your hepatologist and convincing them to order ultrasound of the right upper quadrant of the abdomen or liver, whoever that order, and putting with contrast if indicated. One of my friends had ingenious solution for electronic medical record. He put order for ultrasound of the liver, screening for HCCs, and he put a question underneath. At the discretion of radiologists, can contrast be administered if needed? And his brilliance is by default, he put yes as a check mark. And if hepatologist orders this with this check mark in place, then he can legally do contrast-enhanced ultrasound if needed. That's how we set up our practice as well. We screen those patients. If we see something that needs further characterization, we do contrast. When we do that, we also scan the entire liver in the portal vein looking for something else. But I wouldn't do contrast-enhanced ultrasound to start for every patient who comes to you for screening out imaging.
That's a great question. And actually, so I'll answer slightly differently. I agree with everything that Andrej said. So when you're doing HCC work, it turns out that there's a cohort of patients that can't have MR. And so in my institution and in many others, they don't use CT. They just don't use CT. We don't ever recommend CT and we don't use it. It happens that they have it outside, but we don't use it in our group. And so the patients that can't have MR include patients who are claustrophobic, and there are many of them. Patients who have metal appliances that can't go into the scanner, and then patients that just cannot hold their breath. They have repeated failed MR scans. So that cohort ends up to be a cohort that comes then for ultrasound with CEUS. And so I think that that's a good thing, and it's a good thing for helping your practice to grow. And then an additional thing is that there are patients that turn out to be very, very difficult patients for evaluations. And those include oftentimes patients that on MR have a multitude of T1 bright nodules, and then on ultrasound they have a liver that's just full of nodularity. And so they're difficult because the T1 bright nodule, you're relying then not on a gadolinium image, but the subtraction images on MR. And so consequently, we have a group of patients where I feel that our baseline assessment is so concerning, like there's just nodules everywhere. And oftentimes those livers become very, very nice. In fact, you showed one of mine where there's so many nodules, and the moment you inject the contrast, you can just tell there's neither hyper-enhancement, and in some cases there is hypo-enhancement, which makes you think of dysplastic nodules. And then in the portal phase, they're very, very smooth. And so even though that's not something that's established as a technique, I think that is a place that will use it. But otherwise, I completely agree with Andrej that we have to be quite selective, and the best success we have is when we see a nodule that we can evaluate, like on the baseline scan. So let me ask, how many people in this room have LI-RADS implemented to some extent in their department? Yes, some. And so I'm sure that Richard and Andrej will agree with me. Like, so when we started to use LI-RADS in our department, I was absolutely astonished after about a 6 to 12 month period after we'd been initiated it, like how much more successful CEUS was in the department. And this is related to a few things. Gastroenterologists and hepatologists are used to having these very kind of directive guidelines. And it says to them that you do this if it's this, and you do this if it's this. And so when CEUS just kind of does a nodule and then throws out an opinion that's viewed as the opinion of the radiologist, the personal opinion, well, then the credibility of the ultrasound scan comes into question. And so when we start to use LI-RADS, and Andrej showed beautiful examples, but when we have LR5, for example, like we're not trying to put, like let's say you have 100 HCCs in your population that come across over a year. We're not trying to get all 100 of those HCCs into LR5 because they just can't get there. So that's the ones that he showed us beautifully go into LR4 and LRM. But what does happen is the criteria for LR5 are so stringent. And so if you pick a tumor and say, yes, it's the right size, it's got the right enhancement in the arterial phase, and then it does the right washout in the portal venous phase, and you say this is LR5, well, now they accept it, that this is an ACR-supported guideline and that this is not your opinion as a radiologist. This is your opinion as someone who's following a rigorous guideline for what you're saying. And so somehow the clinicians just really buy into it better. And so in my center, where we've been doing it for so much longer, obviously, because we've been doing it for years before you got a bubble approval, you know, my hepatologists and my hepatobiliary surgeons, they're really, really swung around. And so they put as much credence into a positive LR5 ultrasound report as they do into an LR5 MR or a CT report. And so it's a really great thing. Would you agree? Yeah. It just really makes your department, it just escalates tremendously the believability and the reliance and the requirement for CEUS.
And also, hepatologists and GI doctors, they really hate vague CT and MR reports. Might represent this, however, potentially represent that. They honestly are absolutely in love with LI-RADS for CT and MR because it tells them this is 3, meaning I have no idea, do this is 4, this is most likely HCC, do that. ASLD implemented LI-RADS into their guidelines, so most of the practices who follow ASLD and OPTN guidelines will start using LI-RADS for CT and MR for sure, and then we can add conscious enhanced ultrasound to that as well.
Yeah, and another thing actually too is like LRM, especially LRM, is such an important category. And so we just did a validation study in Canada, and so we ended up with one false positive cholangiocarcinoma went into LR5, was false positive on CEUS and on MR scan. And then all the other cholangiocarcinomas, all of them in our study, which was almost 200 patients, ended up in LRM, which is unbelievable. And then, in addition to all the cholangiocarcinomas, every patient that had metastatic disease, other malignant disease, lymphoma, any other malignancy, they all end up in LRM. So then, when we go to rounds again as well, if I say, this is LRM, we should biopsy this, there's just a whole increased compliance for them to do that biopsy, whereas before, you know, that's just like you say, if it's just kind of your opinion, well, you think we should biopsy it, and I don't think we should, so we won't. And so it's just really, it's a really unbelievable positive thing to do LI-RADS.
Any other questions?
Just to follow up on that, I was just thinking when you do the portal venous sweep, are we increasing the sensitivity for picking up early HCCs or liver tumors? And that was kind of my initial question. Is that worth doing now for these surveillance patients, just to do the sweep and increase the sensitivity?
You know, I don't think that we would have to do too many patients, but I will just make a comment that because I had a different opinion a little bit than Richard and Andrej. So when we do a sweep and we see any area of washout, so then we inject on top of the washout. Yeah, and so that wasn't kind of really emphasized as much. And so the thing is, and so although, so that, I rarely go out of contrast to get rid of bubbles before we re-inject. Sometimes I do, but not so much. And certainly if you have washout areas and then inject on top, it's incredibly helpful to find additional lesions. And so particularly if you're doing secondary surveillance, you always want to do those sweeps because those little small lesions that will show washout will come. Yeah, so that's a great question. So now, a quiz.
All right, so